Welcome to the Jack Westin MCAT podcast with your host, Phil Hawkins.
And Azaii Calderon Muñiz.
Okay, y'all. We're going to preface this whole thing by saying we are not medical professionals. Give me a few years. That's going to change.
I was going to say asterisk yet.
Yes, exactly. But what we're going to be talking about today requires us to kind of give that disclaimer because it's this time of year where it's really easy to be sad, to be down. And so we're going to chat about a couple of things that are a bit sad, are a bit down, but not in content, but rather the concept of these things. And so we want you to kind of get in this mindset of it's winter, depending on where you are, where you find yourself. You might have tons of sun. You might have very little. You might be isolating because it is cold and it's snowing around you. Or maybe you are out at the beach because you live in Florida. So I need to move back to Florida is essentially what I'm telling myself. Yeah. But we're going to be talking about some lower moods today. We'll see if we can keep our mood low while we do it.
I feel like it's weird that you're talking about that and laughing, but I know it's because you're sneaking in like sneaky jokes in there. Like that. I don't know if everyone is catching like sad is actually like, this is the reason we wanted to talk about this is because of seasonal affective disorder.
Yep.
This is something that I have definitely experienced in the past. And this is something that like we were just kind of talking. And I'm like, we should talk about this because I am currently like preparing for a battle of beating seasonal affective disorder. And so just to kind of like take a step back, we should talk about what this thing is that we're talking about. So seasonal affective disorder is something that is very commonly experienced by people, especially in the northern half of the U.S. Because in the northern half of the U.S. in the winter, you get less sunlight. And there's been a lot of research to show that lack of sunlight can lead to a depressed mood. And so this is something I battle with. Like, I feel like every winter, I just start to get kind of down overall. And I think a part of this has to do with like so much of my like career of the last decade. I either work from home or I work in a clinic, and honestly, like work from home most of the time, because it's like I don't have to go out into like the cold, blustery outside, and so I don't. Right, living in Kansas City, it gets like we get snow, it gets cold, like it was in the 20s in the last week. And like, I try to get up every morning and go for walks and things like that. But when it's 20 degrees out and it's dark, right? And like, I really don't want to get up and go for a walk, right? Like that does not sound as fun.
Yeah.
And so I've been trying to do something ever since June. I'm trying to get like 12,000 steps a day. And I've been like super solid with that all throughout, the summer. But like now we're starting to get to a point where like, honestly, I think I've hit that like twice in the last like 2 weeks. And like, I'm like not hitting my things just because I don't want to go outside because it's too cold. And so that combined with just there's less sunlight out there is leading me to get less sunlight than I normally do. And that kind of leads to this sort of depressed down mood. And so every year in the fall, like as winter is approaching, I start to be like, oh man, why do I live here again? Like I need to move back to Florida. I never lived in Florida, but I want to pretend like I did. Well, let's both go, Azaii. We'll both move.
Let's do it.
And do that. I've thought about like, Puerto Rico or Hawaii or something like that. Like I can work from anywhere. Why do I live somewhere where it gets cold and wintry? And man, I sound like an old person. I sound like I just heard myself and I'm like, oh, I sound like my grandma. Like it's so cold. I can't get out. I don't want to go out. Like I need to move to Arizona with all the other retirees. Like that's what's going on in my brain as I'm starting to kind of resonate with that crowd.
It's funny because my grandma, basically all of my family essentially, lives in Puerto Rico. And so she used to live in Jersey though, until my mom and I were like, okay, you want to go back to Puerto Rico? Like, let's just move you. And she's just like, it's so hot. It's so hot. And then I'm like, well, abuelita, at least you're not injured. She's like, no, yeah, that's too cold.
Yeah.
So sometimes it feels like we just can't win with the temperature. I was just thinking, so this thought came into my mind. So because exercise has been shown to help with mood, one thing that you can do to get in your steps, have you ever seen those little like 2-step little thingies?
Like things under the desk.
Yes. Yeah, that and you can basically just put it anywhere and you can just get your steps in. It's like a mini bike. But that can be something that gets a little bit of exercise and doesn't replace the sun, which is critical to this, and the light that's critical to the seasonal affective disorder. But I remember that when I first went, I went to undergrad at U Chicago, and I was talking with, what are they called over there? I don't know what they're called over there. I don't remember, but the advisor, and I was talking to my advisor, and I was just like, yeah, it's so dark. It's like rainy. It's just kind of sucks. And he was actually the one who brought up seasonal affective disorder. I had never heard of it before talking to him. He was like, yeah, a lot of our students here develop seasonal affective disorder, and it takes them a little bit of time to realize what it is. But as as we get ready to move into full-time winter, start kind of prepping ahead of times and thinking about what you can do to stay engaged and motivated, because seasonal affective disorder is real. And I know a lot of people that struggle with it. And here in Boston, especially with a clinical schedule, it can be really tough. And that's something that you're going to experience in med school, unless you go to school in Florida, right? Or Arizona. But when you go out and it's dark and you come back and it's dark, it's tough. And so you need to have other things that you find fulfilling or restorative, because otherwise it can be intense.
Mm-hmm. Yeah, for sure. And this is something, like we've said, this is something I think happens to a lot of pre-med students, a lot of medical students, because you have a very intense academic schedule. And so if you're going to med school and you're staying there for 10 or 12 hours, studying, doing labs, doing whatever. And so it's dark when you go there and dark when you come back. That's something I experienced myself. And I'm sure you're dealing with that, Azaii, or you have dealt with that. And so this is something that is just kind of important, I think, for this audience, the people listening to us. This is something that either you may have to deal with or you might already be dealing with. I do feel like we should take a second and just kind of step back, because what we're talking about is mood stuff. And I later on, we're going to kind of separate this from some other things, because I know students kind of get confused about mood, but mood is like a spectrum, right? You have a high mood and a low mood, right? Mood is not something like happy, sad, angry, fearful. I think about last week's episode. It's not emotions. It's like high and low. It can be depressed or it can be manic, right? Which is the other end of that spectrum. And so I think most people are really comfortable with the idea of depressed, right? A depressed mood, which is low mood, right? You don't feel great, right? It's everything's kind of down, versus a high mood is mania. And I always think mania on the other side of this, I always think about just cocaine is the way I think about that. And maybe the way it's depicted, because cocaine causes mania, where it's everything's great, everything's awesome. There's just kind of this very high mood. And so I want students to know that mood is a spectrum from low to high. And what we're talking about today is mostly stuff on this low end, right? And so seasonal affective disorder is something that occurs with a depressed mood, where it's lower than normal, but it's not the only thing that causes depressed mood. And so we're going to talk about a couple of other things in this as well, and try to pull these things apart. And so we want to talk a little bit about dysthymia, which is another kind of area in this.
Yeah. And I think this is also where timing can be helpful in terms of conceptualizing what we're going to be talking about. So yes, listen to, the symptoms and kind of the intensity, but also the timing, and that's going to help you identify the differences. So with dysthymia, it's helpful to consider it in comparison to depression, which we're going to talk about in a minute. But dysthymia is this very long-lasting, more subtly lowered and depressed mood. And so people might find themselves consistently feeling sad or anxious, sometimes even just empty. They're going to have a little bit of a harder time concentrating, right? Maybe that kind of higher activation energy to actually make decisions because they are lower energy, constantly feeling exhausted or fatigued. So notice that this is not far off from what we talked about with seasonal affective disorder. But at this point in time, we said it's really long lasting, right? It can be on the point of years. And so, this, you might feel hopeless or something that a lot of times is a unhealthy coping mechanism that people use when they're feeling down or when they have difficulty with depression is like going to food, right? And so food can be a very tricky topic for a lot of people because that's something that a lot of people end up going to. And so with dysthymia, it's this lower mood. And so it's more mild, right? More mild to moderate, not super intense, but it's very long lasting. And that's one of the differentiators from dysthymia, seasonal affective disorder, and depression. Recognizing that, I don't think we said this explicitly, seasonal affective disorder, right? As the weather, gets colder and light goes down, et cetera, basically winter is when it's going to peak. But as you move into spring, into summer, that no longer applies. So if someone is still experiencing these symptoms, middle of summer, totally bright out, right, going out, getting a lot of light, time to reconsider if that's actually seasonal affective disorder or maybe something that's building into like dysthymia.
Yeah. And I mean, you could in theory have dysthymia and it just tends to get a little bit worse in winter. And so it could be like both of these kind of piled on top of each other. Yep. But I think when it comes to these like depressive things, most people are just most familiar with major depressive disorder, which most people just call depression, right? Yep. And so that tends to be the most severe of all of these, compared to dysthymia. MDD, or major depressive disorder, is much more extreme. It does tend to be a little bit shorter lasting of the two, although it can be long lasting in theory. It's just you don't like, in order to diagnose dysthymia, you have to have had it for a long period of time. Major depressive disorder, you don't need as much time to be able to diagnose that. But it is kind of interesting, like the two of them. I don't want to downplay major depressive disorder. Super serious. Definitely need to deal with it. But I think that there are some, like dysthymia often goes undiagnosed because it's not as severe. And so people and a lot of times with like major depressive disorder, it can get really severe to the point where people don't get out of bed, right? And they just like stay in bed all day long. And generally, if you know somebody who is going through major depressive disorder and they have symptoms that severe, you're going to step in and do something. And so like a lot of times people going through major depressive disorder will see a physician and will see a health professional. But if somebody's just kind of like a little bit down all the time, and especially if they're like that for years, like you kind of just think, oh, this person's just kind of a down person, right? Like that's just their normal. And so a lot of times people with dysthymia don't get it diagnosed. And also, like, interestingly, dysthymia can sometimes be harder to treat, right? In terms of like how well it responds to treatment. We have some really great ways to deal with major depressive disorder, both through medication and through therapy and things like that. Dysthymia tends to be a little bit more stubborn and a little bit harder to treat overall.
Yeah. And that's not to say that we don't try medications or therapy, right? We're still going to, because we don't want to have someone who, has dysthymia to just suffer, right? Yeah. So we still, even though, that may be the case, we still try and act on it. Something else that you might be recognizing that is kind of woven itself into all of these is effect on sleep, right? And so all of these conditions can be worsened by a lack of sleep, but they're also characterized by sleep disturbances. And so, like you were saying, someone with an episode of major depressive disorder might not get out of bed. And so it's going to get even harder to do what they need to do, what would bring them, more rejuvenation, peace, etc. And I think it's important to recognize that, like we said, and we said it, I said it like fairly jokingly, that we are not medical professionals, but at the end of the day, we truly are not. And so if these things are kind of resonating, seek out help from a mental health professional. A lot of times, undergrad institutions, graduate institutions, they will have mental health services on campus. And so if you're still connected with your undergrad graduate institution, that's usually covered under the student life fee that is assessed for everyone. So that's something to think about. With depression, so like you said, mood is really a spectrum, right? And so we've focused on the lower end of the spectrum with seasonal affective disorder, shorter, right? More contained. Dysthymia, very long, more mild, tougher to diagnose than major depressive disorder, which can come as discrete episodes or can be longer lasting. A lot of it depends on what activators and triggers and what's happening, the events that are happening in people's lives. But there's also this other category that encompasses both ends of that spectrum. And those are the bipolar disorders. And so right off the bat, and I think we've said this when we have mentioned it in the past, this is not the movie Bipolar Disorder of someone whose, mood is changing 10 times in one day, right? Like, oh, you're super happy, but then in the afternoon, like you're crying, and this happens every day. That is not bipolar disorder, to be very clear on that. So bipolar disorder, depending on the type, there's type 1 and type 2, will encompass different things. So type 1 is this idea of mania. So if you have a manic episode, you are diagnosed, let me back up. That's assuming that it's not attributable to drugs, right? Not attributable like cocaine or something else or some other medical condition. But in the absence of those things, which are known to cause mania, if someone develops or if someone experiences a manic episode, they will be diagnosed with bipolar type 1. May or may not be accompanied by depression, right? But in this manic episode, people are doing things that are very outside of their norm. So a lot of times folks will have this kind of grandiosity and feel like they can take on the world, and they might start a bunch of projects that are unreasonable and really focus on those projects. They are less risk averse, like we talked about last week. I heard a story of a patient who like bought a car, sold a bunch of their stuff, and just started driving across the country. Mania is very serious. It can leave someone in a lot of financial debt. It can leave someone hospitalized. And so it's fairly easier to identify a manic episode. On the flip side of that, you have bipolar type 2. And so bipolar type 2 is actually dominated by depression, not this higher mood. So bipolar type 2, a lot of actually times what is done is we'll focus on treating that depression rather than the hypomanic episodes. So if you have a manic episode, type 1. If it's hypomanic, it's type 2. And so hypomanic is almost like, it's similar to the dysthymia of depression. The issue is not timing, right? It's severity. So it's going to be lower. You might be talking really fast. You might have a lot of those same symptoms. You might not need as much sleep, but it's not interfering with your daily life to the degree that mania would. And so that's why it can be harder to diagnose. But we're going to treat that depression the way we would with major depressive disorder. Caveat that you don't need to know for the MCAT, but I think it's important if you move, assuming you move forward and maybe you like psych, you would not do like something that activates without something that calms in any bipolar disorder. Hopefully that makes sense, because you don't want to treat the depression to the point where now you're precipitating
Panic all the time.
Exactly. So it's a fine balance. And psychiatry in general is a very fine balance, and a lot of playing with medications to figure out what's a good fit for someone, because sometimes things work and sometimes things don't. But I think it's important to also talk about how these two disorders fit on that spectrum and the relationship that depression can have with both of them.
Yeah. And that's, just like bipolar, like that means just two poles, right? And so bipolar is this like moving between like the mania depressive thing. And that's also why, like whenever we give medications, we don't just want to lift everything, right? With depression, you want to lift, right? And like, that's it. But with bipolar, you want what we call a mood stabilizer. We want to kind of like stabilize and kind of pull it to the middle. It's really interesting that like a lot of times people who have bipolar kind of don't want medication, or they don't like the medication because it gets rid of that manic state. And the mania feels good, right? It feels good to be like, I'm on top of the world. Everything's great. Nothing can go wrong. I don't need to sleep. I got tons of energy, right? And it feels good. But like you said, it can be dangerous, especially financially, right? Like people who are in this manic state will feel like nothing can go wrong. And they'll do things like, I'm going to get rid of I'm going to sell my successful business because I want to start an emu farm, right? And I'm like, I don't know what I've never worked on a farm. I don't know anything about emus, but I'm going to do it. And right, like that's like, ooh, like all of a sudden you now have a house and you have 6 emus and you have no fences and you don't have a business and you lost all your money. And like, that's probably not a good idea going through this. And so mania can be bad as well, but the thing is, mania feels good. And so like it's sometimes a little bit tricky going through this. And yeah, this type 2 does have mania that's not quite as intense, not quite as severe. There's also a third thing called cyclothymia, which is actually, it's kind of like less severe of both. Right. And so it's kind of like a little bit depressive and a little bit manic and just kind of like going through this. That also tends to get diagnosed less often because it's less severe and the symptoms are less severe. And so people are less likely to run to the hospital. But yeah, so these are things that you need to kind of like keep in mind and just kind of balance overall.
Yeah. And having worked with so many patients with different mood disorders, I want to be very clear. We're not painting a picture that, mania or hypomania are good, like that they, that patients should seek after them. There are a lot of patients that have a really bad crash, a really bad mood drop that can sometimes be even worse than their original depressive state after these episodes of mania or hypomania. And so these come with consequences, not just financially and, external life, but also they have, for some patients, really intense mood consequences afterwards. And so that's where it gets really tough to kind of find that balance of treatment and whatnot. But I think this is a great opportunity to think about, okay, well, we're talking about mood, but not everything is a mood disorder.
Yeah. And so this is something a lot of times students get kind of tripped up between like bipolar and which we've been talking about, and borderline personality disorder, or like a lot of these other disorders that are focused on emotional dysregulation, right? And this is once again kind of like focusing on the difference between a mood and emotion, right? And those are two separate things, right? And so if you are dealing with depression, dysthymia, cyclothymia, bipolar type 1 or 2, seasonal affective disorder, those are mood disorders, right? And that's kind of bouncing between this depressed and mania and this like, or something on the spectrum, something's off a little bit. That's different than people who have emotional instability, where they're like angry and then happy, or just kind of bouncing between emotions, like you see in borderline personality disorder. But there's a difference between mood and emotion. And I really want students to like be able to separate those, because a lot of times, like in the real world, like somebody will say like, how you feeling? You're like, I'm feeling good, right? Versus I'm feeling happy. Like, and a lot of times that means the same thing in like everyday language. And I just want to kind of shine a spotlight on like, I want students to like separate mood versus emotion. Those are not the same thing at all. And that's something you have to be really careful with, because the MCAT writers know that students get tripped up on those. I do want to reiterate, obviously, this is the MCAT podcast, and everything we're talking about here is stuff that's actually testable. You will get tested on bipolar type 1 versus type 2. You will get tested on dysthymia, depression, seasonal affective disorder. We're not just talking about this because all of a sudden I am sad because winter's coming. But this is all actually testable stuff that they're going to hold you accountable for. And so you want to make sure that you're comfortable with that.
Yeah. And that's why we specified like when something was not testable or you did not need to know it for the MCAT. But yeah, I think that's also, like you just said, like highlighting that spotlight, because even when we're thinking about, and when we ask patients, when we're screening for depression, we use words like sad, right? And so it can be tough to really differentiate the two in common language. And that's going to affect how we interact with people outside of the exam.
Right. Right. There's also some interesting like diagnostic criteria for depression. And there's some great mnemonics out there. And I know, Azaii, you have a great mnemonic for this. But I'd want to kind of take a moment and just, there's something called anhedonia, which is something I know the MCAT has asked about this. And so you want to be comfortable with this term of like, what is anhedonia? So anhedonia is like a lack of interest in things that you used to be interested in. And so this is something that happens with people in depression. And it's also what makes it hard for people who've never experienced depression to kind of understand this, right? And they're like, oh, you're sad? Like you're depressed? Like, why don't you just go, like go with me to play with some puppies, right? Like that'll fix your depression, right? Like that's not really how it works, right? Depression there's a neurological change here. And a part of this is this anhedonia, this being in a place where things that normally would bring you joy will not bring you joy anymore. And this is one of the reasons that people who have like major depressive disorder, that they'll like stay in bed because like, you're like, oh, why don't they go watch TV or play a video game or read a book? Like those things make you happy. And like these people just aren't interested in those things. Like that doesn't make them happy anymore. It used to make them happy, but now it doesn't. And that's this like lack of this. And so I just want to like reiterate that term anhedonia or anhedonic. Those of you who are linguists might note the hedonia, or like hedonistic is like, joyful, like something a little bit kind of like extreme. So anhedonia is the inability to feel joy, even if you're like surrounded by puppies, right? Like it doesn't make it so that all of a sudden you feel great again.
Yeah, that's why every time like I see a school or a workplace or somewhere and they're like, oh yeah, like, we care about your mental health. And then they do things like a ping pong table or, some puppies. It's like, nice thought, not quite going to fix the underlying issues. Yeah. But yeah, so you mentioned a mnemonic. So the mnemonic for the different symptoms is D-SIGI-CAPS. So the D just being like that depressed state. And we'll often ask patients, between a 2-week to a 30-day window. And so that's why what you were saying earlier is important, that, we don't need as long of a time frame to diagnose major depressive disorder compared to something like dysthymia. Then we have those sleep disturbances, right? That sleep changes that we talked about, interest. So the anhedonia comes into play. People can also feel guilty. I don't think we talked about this. And just kind of like also down in terms of their energy and not just their emotions. Can also be, like we talked about, harder to concentrate. Your appetite or your relationship with food might change. You might like kind of slow down, right? Just like people might notice that, like you were saying, people that know you might notice when you're having these changes in a major depressive disorder. And then of course, people who are experiencing major depressive disorder can have suicidal thoughts. And so it's important to like be willing to have those conversations with people around you in case, someone is having these thoughts, and making sure that we're just being present for other people can be really helpful.
Yeah. Just one more time in case anybody's like listening or taking notes. It's D-SIGI-CAPS: depression, sleep, interest, guilt, energy, concentration, appetite, psychomotor, which is what you're talking about, which is kind of like slowed down overall in terms of activity, and then suicide ideation is the last S.
Yeah. So what kinds of things can we do, right? Aside from medication, aside from therapy, seeking professional help, maybe, petting a dog won't hurt, right?
No,
it's not going to hurt. And with something kind of lighter and more temporary, like seasonal affective disorder, that could be a little bit helpful, right? But it's not going to ultimately change what's causing the lower mood. So one of the things that for seasonal affective disorder, at least, was something I heard about very early, are these light therapy boxes. And so essentially, I may or may not have prepared it for this. Essentially, they just provide light that is thought to be more similar to like the light that we get outside,
like mimicking sunlight.
Yeah, with sunlight versus like, the incandescent light bulbs in homes and things like that. So we got our light boxes ready because it is getting dark here. And I may or may not have put up, what is it called? The light blocking blinds.
Blackout curtains.
There we go. Yeah. Blackout curtains. I said the correct term earlier. Apparently I've lost my words, but I put a blackout curtain so I can actually sleep. But now I'm going to have to be taking those down and actually adding additional sources of light to my home because like you, Phil, I will be doing things mostly from home while I am studying this coming month.
Yeah. So this is something that like basically what you're doing here is if the problem is you're not getting enough sunlight, just get more sunlight. And so we have these special lights. They're not just like normal light bulbs because these lights are mimicking sunlight with the right wavelengths. I will say that they are missing the UV rays that come from the sun because UV rays can be somewhat dangerous. UVA versus UVB. So they can't give you a sunburn, which is good. But like the idea here is like, oh, let's turn on these lights earlier in the morning. And all of a sudden it's like the sun came up at 6 instead of 8 when it is actually going up, or 9 due to daylight savings and kind of like shifting time frames. And so this is actually something I've ordered one. I've got one coming. I used to have a light box. I had it in med school. And so I will say the first time I had very serious seasonal affective disorder and was diagnosed with this was my first year of med school, which is the time I was doing the most studying, staying in the labs and staying in classrooms. And I just was not getting outside like at all. And there were some things that I did that made things better for me. And like one was the light and just making it mimic sunlight more. I know I've talked about this before, but in like some different things like the newsletter and different stuff that I do. But that's actually when I first got a dog. And so I got Millie, who was a Great Dane named after Millikan, the discoverer of the electron. And getting that dog like for Christmas meant that all of a sudden I had to go outside more. I had to take the dog for walks. And this did kind of a couple of things. First off, it meant that I was getting more sunlight. It also meant that I was exercising more because I was being forced to kind of go out there. And I think that exercise, at least for me, I'm not saying this is how it is for everyone. At least for me, I think that's a big contributor to this as well. So like, it's not just the lack of sunlight, but it's also like, I don't want to go outside. And so I'm also getting less exercise. And so both of these things together make things a little bit worse for me. Like exercise helps. Exercise can be a mood elevator if you have a depressed mood. And that's been something that's been shown in lots of different experiments. And so there's just some kind of a perfect storm that happens in winter where I'm getting less exercise and I am just not getting enough sunlight. I'm usually gaining weight as well. As you mentioned, like it'll change your relationship with food.
Doesn't help that the holidays are also there. It definitely, and then, coming together for food.
Yeah, it definitely doesn't help then. But one thing that can also help is try to align your schedule more to the light. Like if you do try to get up and go for a walk in the morning, trying to do it in the light is better. I know that is just not possible for me. The sun is coming up later in the morning. Before I was going for walks in the sunlight in the morning, and now I just can't because I got to go to work and there's just not enough time in the morning where there's sunlight available. But this is actually one of the things I'm excited about. I said that I ordered a light therapy lamp, and I kind of want to set it up to a timer in my bedroom so that all of a sudden the light is coming on and it's mimicking, like in my bedroom, it's essentially going to be daylight, but like an hour before the sun actually comes up. And so trying to get my body on a better kind of like rhythm throughout this is something that's important.
Yeah. And again, to be clear, like the things that we're talking about do not replace like professional help. And they are not a cure to these things. They're just things that we want to share that can be helpful. Right. There's a timer on mine, like the different settings. So I as I progressively wake up, I turn it up a little bit brighter. Something else that, and I want to say this because I'm pretty sure I've mentioned it in the past, but there are some studies that show that rigorous, well-planned, right, with the help of a physician in those cases, exercise programs can be as effective as medications at times. So even unstructured, that tells us that doing exercise can genuinely help with mood, at least to some extent. Again, right, it depends, because most of us are not seeing a doctor for a structured exercise program.
Right.
So we make do with what we can. But exercise is really powerful. And so even if you can't go outside every day or at a particular time, incorporating exercise can be helpful. It's tough because, like we talked about, you can have that lower energy, that kind of higher activation energy to do things. But it's something, if you can build it into your schedule, can be super beneficial. Something else that some studies have shown that is interesting. So sunlight, right, helps our body convert essentially vitamin D to its active form. Taking vitamin D supplements in some studies has shown to help people with their depressive symptoms. And so that's something else that I have my vitamin D. I just got it not that long ago because we're pulling out all the stops. I think I've shared this before, but I've struggled with depression most of my life, despite the fact that I'm always trying to like smile and laugh during these things. But it also during the podcast, but it also gets worse in the wintertime if I'm like isolated, not going out, doing things. Definitely got tougher last year when I was, in and out of the hospital when it was fully dark. But again, these are just like small things that you can do if you have access to them that can be helpful. And let's say that you don't. Maybe it means that on your lunch break at work, you're going to go outside because there's going to be some sunshine at noon. Or maybe you move, you're studying in your room, maybe you move your desk to the window so that when the sun comes out, you pull those curtains, right? And you at least have the sun facing you, even if, right, you're not going outside because it's snowing. And so there are lots of little things that we can do that aren't perfect, won't solve the problem, but can help mediate some of these tougher symptoms that a lot of us experience when we're going through any of the disorders that we talked about, whether it's seasonal affective all the way to bipolar, small things that we can do to try and make our lives a little bit easier.
Yeah, I do. Just in case students might be thinking this, I've been doing a lot of research on these light therapy boxes and light therapy lamps because I knew that I wanted to get one. Students might be thinking like, oh, I'll get a light therapy lamp and then I won't need like vitamin D stuff. My vitamin D levels will go up. Note that in order to convert the vitamin D, you actually need UV, I think it's UVB. So you need some ultraviolet rays, which these light therapy boxes do not create. And so it's the wrong wavelength. It's not high enough energy photons. And so the light therapy boxes have been shown to help for sure, but they're not going to fix the vitamin D issues. For that, you need ultraviolet B, which you can get from the sun, but ultraviolet rays also, you don't want to get too much of them, so that could be kind of problematic. Another way to do is to just take vitamin D, and I've got vitamin D supplements on my desk as well, because I've noticed at least it might be placebo effect, but it feels like it's helping for sure.
No. So I actually have a meta-analysis pulled up, and the effect is essentially like a 40% drop in symptoms. So yeah, so it does. There are studies that show that it helps. TBD on which ones are most recent and provide the most accurate numbers. But these things do help. Since again, I'm in Boston, right? That's no surprise. A lot of the doctors that I've worked with, they prescribe vitamin D like it's candy. The assumption is that if you live in Boston during the winter, you will likely develop vitamin D deficiency if you aren't already vitamin D deficient. And so a lot of the PCPs, right, like the primary care docs and like pediatricians, they just vitamin D, let's go.
Yeah, and that's something that I think at this point, like a lot of the medical community just feels like pretty much anyone above a certain latitude, like they just should get vitamin D, especially if, I know I talk about this a lot, but if you think about like evolutionarily, kind of like what's happening, like you turn back the clock 2,000-3,000 years, nobody is going inside of a room and sitting there inside all day, right? Like people are hunters and gatherers and going around. So like we evolved to kind of live in a place that's got a lot of sunlight. Even during the winter, like we were still outside and like getting sunlight. And in today's world, like, I mean, there's probably people who live in, you know, like in places that have a lot of sunlight in Mexico that still might not be getting enough sunlight. If they're like staying inside and working inside all day. And I know, at least for me, things got much worse for me when I got into med school, because I was in a very rigorous program. I was spending lots of times in labs. I actually don't know, Azaii, if this is something you noticed, but I did actually a lot of interviews for med school and interviews for research on the East Coast, like in Boston at like MIT and Harvard and places like that. And it was kind of interesting because all of those buildings were so old. And so a lot of them are like really thick brick, and there's like not very many windows and things like that. And so I noticed like there were a couple of labs I went and like interviewed at. I'm like, I walk into the lab and like there are no windows. Like there's no light. And I felt like I ran into that a lot on the East Coast versus West Coast and middle, where like the buildings were much newer. Like the lab I worked in Omaha had just like one wall of windows where it was all just glass and you're overlooking the city. And it was really pretty and great. And I'm like, I'm getting sunlight. But I remember thinking like, oh man, I'm so glad that I'm not like in that lab in Boston where I'm like just trapped in this like concrete box with no sunlight at all. Mm-hmm. So that might also be a thing to think about, is like the environment that you're in. If you get an option to like study at your school or med school, like in a place with a window, not a bad idea. If you get a chance to like eat your lunch in a place that has windows, like rather than, you know, going back to your classroom where you're like, you've been sitting and studying, or study room or whatever that has no windows, doing just little things like that can make some big differences. Or at least they have for me. We definitely should reiterate, I know we said this at the beginning, we said it in the middle, we're going to say it at the end as well. We are not like medical professionals. We are not diagnosing you. We are not giving you treatment plans. We're just giving some anecdotal advice and some understanding of disease and things like that. So definitely talk to a medical professional, or talk to somebody if you feel like you might be going through some stuff kind of like this. But just getting that information out there.
Yeah. As always, right? We are here to make this experience more enjoyable in terms of the MCAT. What we talked about is testable, right? That's why we made this podcast episode. So make sure that you understand the concepts and the differences between these. But like you said, always reach out to someone if you find yourself having difficulty with your mood, with things like that. We encourage you guys to take care of yourself while you're studying. And with that, get some sunshine and go off and do fantastic things.